Welcome to the Therapy Council's podcast.
Glad to be here for this one.
Yeah, so, when we usually talk about art, I think we picture a really relaxing Sunday afternoon.
Right, like sitting by a window.
Exactly. Maybe you got a sketchbook, some watercolors, or maybe one of those intricate adult coloring books that got so incredibly popular a few years
Right,
ago.
yeah, those were everywhere.
They really were. And it's calming, right? It's an escape. But today, our mission for this deep dive is to kind of separate the rigorous clinical reality of art therapy from those casual coloring book trends.
Which is such a necessary distinction to make right now.
It really is. And we are using a fantastic, just incredibly comprehensive guide published recently by Pragya Alexander. It's titled Art Therapy Certification, a Complete Guide.
A really vital piece of work.
Yeah, it came out on July 30, 2026. And I have to say, reading through it entirely shifted my perspective on what actually happens when putting pen to paper crosses over into a professional, psychological intervention.
It is a phenomenal document, mainly because it tackles a very modern, widespread problem.
Right.
We are seeing these creative methods popping up everywhere in clinical counseling, physical rehabilitation, even corporate mental wellness programs.
Yeah, HR departments love a good creative workshop.
Exactly. But this guide anchors the conversation back to reality. It sets our core theme right out of the gate, which is that handing someone a paintbrush is not inherently therapy.
Yeah, that stood out to me immediately.
True art therapy requires the exact same level of care, ongoing consent, and professional judgment as any other clinical therapeutic intervention.
So it's not just having a good attitude and a box of markers.
No, not at all. It is a highly specialized skill set.
And that distinction is exactly why we are tailoring this deep dive for you, the listener.
Yeah.
Because the learner in this context could really be anyone.
For sure.
Like you might be a practicing therapist looking to upskill and add visual methods to your repertoire. Or you might be that HR professional tasked with handling corporate mental health initiatives.
Or you might just be insanely curious about how the brain, art, and psychology interact.
Exactly. Whatever your background, this guide provides the roadmap. So we have to start by drawing the lines around what art therapy actually is, and probably just as importantly, what it isn't.
Right. Getting the definition straight is step one.
The source gives a very strict definition. It says it is a mental health practice integrating creative activity, psychological theory, and a professionally governed therapeutic relationship.
The precision of that definition is just crucial. The source breaks this down into 4 non-negotiable elements.
Okay, let's unpack those.
First, you have the creative activity itself, which is broad. It could be drawing, painting, collage, clay work, photography, or even digital image making.
Okay, so a wide net for the actual art.
Right. Second, you have psychological understanding. The art making isn't happening in a vacuum. It is actively informed by an appropriate therapeutic framework.
Makes sense.
Third is the therapeutic relationship, which is governed by consent, confidentiality, and professional boundaries.
And the fourth one.
The fourth element, which honestly often gets misunderstood, is reflective integration.
Wait, I really want to pause on that fourth element, reflective integration.
Yeah.
Because the source makes a massive point here, that meaning should not be imposed by the practitioner.
Yes, that is a huge takeaway.
Like a color, a shape, a symbol. They do not carry a universal diagnostic interpretation.
Absolutely not.
So if a client draws a dark, swirling cloud, the therapist doesn't get to just look at it, tap their clipboard and say, yes, a black cloud. That means you are clinically depressed.
Right, it's not a party trick.
The client has to lead that meaning.
Right, exactly. That urge to interpret is arguably the biggest trap for untrained individuals trying to use art in a therapeutic way.
Why do you think that is?
It stems from a desire to be the expert, one who decodes the client. But the guide provides a comparative table that illustrates why this matters so much.
I found that table incredibly helpful.
It contrasts art therapy with therapeutic art activity, art education, expressive arts facilitation, and recreational art.
Which all sound the same to a layperson.
They really do. The lines between these seem blurry to the general public, but functionally, they come down to consent, competence, documentation, and safeguarding.
The analogy that came to mind while reading that table is the difference between cooking a healthy meal for a friend versus prescribing a medical diet.
Oh, that's a great way to put it.
Right. Because both are good and both have benefits, but the claims and the responsibilities are just completely different.
Completely.
Like, if you cook a nice meal, your friend feels good and enjoys the evening. But if you prescribe a medical diet, You are taking active professional responsibility for their physiological health.
You are making a medical claim.
Exactly. You are making a claim about outcomes, and you better have the credentials to back it up.
I'd actually push that analogy even further into the legal and ethical realm.
Oh, yeah. How so?
Well, in art education, for example, the primary purpose is developing artistic knowledge and technical skill. There is no therapeutic relationship required.
Right, you're just learning to paint.
Exactly. And making clinical claims there would be entirely inappropriate. Now, a therapeutic art activity may be facilitated by a community worker, might be for well-being or self-expression.
Which is great, but still not therapy.
Exactly. Again, no diagnostic or treatment claims can be made. Art therapy, however, is psychologically informed work requiring that therapeutic relationship.
So the stakes are way higher.
Clinical claims are made, but only within the practitioner's legal and professional scope.
Okay, let me throw a scenario at you then. Let's say I am a certified counselor. I am already a professional, already licensed in talk therapy.
Okay, I follow.
If I decide to just add a drawing exercise to my standard Tuesday afternoon talk therapy session, does that suddenly make me an art therapist?
The source is unequivocal on this, no.
Really, even with a license?
Even with a license. Introducing a creative task to a counseling session does not automatically turn the practitioner into an art therapist.
Wow, okay.
The practitioner must understand the unique psychological mechanisms triggered by visual expression.
That makes sense. It's a whole different tool.
Exactly. Similarly, if an HR facilitator provides creative well-being activities for a corporate retreat, they cannot advertise those activities as psychotherapy.
Even if everyone cries and hugs at the end.
Right. Regardless of how cathartic the employee has found it, the practitioner cannot adopt a protected title just because they brought art supplies into the room.
So if setting up these strict boundaries around the definition is the first step, it really begs the question, how does a professional officially prove they have the skills to cross that boundary safely?
That is the million-dollar question.
Right. If just handing out a sketch pad doesn't make you an art therapist, how do you prove your competence? This leads directly into the messy world of credentials, specifically certificates versus licensure.
And the credential landscape is notoriously confusing.
Oh, it's a nightmare.
Terms like certificate, certification, registration, and license are thrown around interchangeably by the public, but they carry vastly different weights in the professional world.
Which the guide points out clearly.
It does. It lays out a credential matrix to cut through the noise, and it focuses heavily on why professional certification matters functionally and legally.
Let's bypass the basic attendance certificate. We all know what that is.
Just showing up.
Yeah, you sat in a webinar for 3 hours, maybe you were answering emails on another screen, and you got a PDF saying you attended.
There's no assessment there. It just proves you existed in a space.
Exactly. But the guide heavily emphasizes professional certification. It states this requires completion of defined learning and assessment requirements, proving assessed competence in a specific area.
Assessed competence is the key phrase.
But I have to push back here on behalf of the listener. Art is so subjective. How do you assess someone on something where there is no right or wrong drawing?
It's a fair question.
Right, like how do you actually grade an art therapy exam?
That is the exact misconception that trips up people outside the field. The assessment is not grading the art. The certification program is grading the practitioner's professional judgment. Assessors are scrutinizing the therapist's decision-making process.
What kind of decisions are they looking at?
They are asking, can this practitioner identify sensory risks in the materials they are providing? Do they recognize when a client's trauma response is outside their scope of practice, which necessitates a referral?
So it's about safety.
Exactly. Do they understand the specific psychological theory behind why they are introducing clay instead of colored pencils at this specific moment?
That is fascinating.
Certification doesn't magically override local laws or grant a statutory license to practice psychology, but it provides hard, evaluated evidence of structured professional competence.
That makes total sense.
Yeah.
We're not grading whether the client drew a structurally sound house with perfect perspective.
No, not at all.
We're grading whether the therapist understood how to safely facilitate the client drawing their house. And more importantly, how the therapist managed the emotional fallout if the client suddenly experienced a panic attack triggered by the memory of that house.
Precisely. You are evaluating the containment, the boundary setting, the ethical reasoning, and the theoretical application.
Wow.
If a practitioner cannot explain the clinical rationale for an intervention, they fail the assessment.
Right. They can't just say, I felt like using paint today.
No. The concept the guide uses here is assessment gating. A credible program cannot just let people pay a fee and walk away with a title.
They have to pass through the gates.
They have to pass through rigorous gates, conceptual exams, ethical decision-making scenarios, case formulation exercises, and reflective practice submissions.
Which naturally leads us to wonder what is actually inside those gates?
Well-
What is being taught to pass these assessments?
A curriculum is dense.
The source outlines some very specific pillars of a credible curriculum, the practitioner's toolkit. The first pillar it lists is psychological foundations.
And it covers a lot of ground.
It really does. The guide lists an intimidating amount of frameworks: person-centered and humanistic theory, psychodynamic approaches, cognitive and behavioral frameworks, attachment-informed practice. I mean, it even goes into systemic approaches and trauma-informed principles.
The necessity of those frameworks becomes clear when you look at how they change the actual session.
How so?
Let's compare a cognitive behavioral framework to a psychodynamic one.
Right.
A practitioner using a cognitive behavioral approach might use art to help a client map out their thought patterns, perhaps drawing a literal flowchart of how a specific trigger leads to an anxious behavior.
It's very structured.
Right. The art is used to restructure conscious thoughts. A psychodynamic art therapist, however, might use completely unstructured painting to explore unconscious conflict.
So just free painting.
Yeah, looking at how the client's past is manifesting in the present creative process, the theoretical orientation dictates the entire structure of the intervention.
That's wild. Okay, so the second pillar, creative media and material awareness, is where the specific mechanisms of action really click for me.
The materials are never just materials.
Right. The source explicitly states that material choice is not neutral. It explains that something like clay might feel deeply grounding and tactile to one client, helping them center themselves.
Now, for another,
It could feel entirely overwhelming, messy, and totally out of control.
we need to look closely at the mechanism behind those reactions. Different materials require different levels of physical and emotional control.
Okay, tell me more about that.
Pencils and fine tip markers offer high control. A client who is feeling chaotic might desperately need that boundary. They need to contain their expression in small, deliberate lines.
That makes perfect sense.
Conversely, large-scale, wet media like watercolor or heavy paint on a massive canvas encourages freedom and fluidity.
Which sounds nice, but
But for someone with complex trauma, that loss of spatial containment, the feeling that the paint is running everywhere and they can't control it can actually trigger intense hyperarousal.
I hadn't even considered the physical dimensions of the canvas. It's not just the medium, it's the space it occupies.
Exactly. Space is a boundary, too.
And beyond the psychological impact, the guide brings up highly practical physical concerns regarding materials, like toxicity, ventilation, allergies, infection control, and sensory sensitivity.
This is so important. Applying this to the HR listener we mentioned earlier, imagine you are setting up a corporate wellness art session in a small, windowless conference room.
Oh boy.
If you bring in heavy oil paints or toxic solvents without understanding the ventilation requirements, you are creating a literal physical hazard.
They're poisoning the accounting team.
Basically, or consider bringing in textured, messy materials without knowing that an employee has sensory processing issues. For that individual, being asked to touch wet clay isn't relaxing. It causes severe neurological distress. Specialized training teaches the practitioner to anticipate and mitigate these risks before they even open the art supplies.
That perfectly sets up the next curriculum pillars, which are relational competence and assessment literacy.
Those are critical.
This is where the practitioner learns to offer structure without controlling the client's meaning. We touched on the danger of interpretation earlier, but the guide heavily emphasizes the danger of reductive statements.
Oh, the cheat sheet approach.
Yes. Teaching that red means anger or a small figure indicates low self-esteem is not just incorrect, the text actually calls it clinically misleading.
Let's illustrate why that is so dangerous. Imagine a novice practitioner working with a young child.
Okay.
The child draws a figure heavily shaded in red. The untrained practitioner, relying on internet myths, assumes red universally symbolizes aggression or buried anger.
Because they read a blog post.
Right, and they begin questioning the child about who they are mad at, steering the entire session toward conflict.
Oh, wow.
What they failed to ask was what the color meant to the child. Who might simply be drawing their favorite superhero whose primary color happens to be red?
That is a brilliant example.
The practitioner has imposed a pathology where none exists.
The text explicitly says a practitioner has to tolerate ambiguity. They have to distinguish between an observation, like the client used a lot of red, and a clinical inference, like the client is angry.
It is a vital distinction.
But here's where I get a bit confused. The source talks a lot about reflective practice and the practitioner's urge to rescue or interpret quickly.
Yes, the rescue impulse.
Why is the therapist's own reaction so dangerous here? I mean, if I am a naturally empathetic person, shouldn't my reactions help guide the session?
Deep empathy is necessary, but unexamined reactions are dangerous. Art evokes strong, immediate, visceral responses.
Right.
If a therapist isn't engaged in deep reflective practice, they are at high risk of projecting their own cultural assumptions, their own artistic preferences, or their own unresolved emotional baggage onto the client's work.
Give me an example of what that looks like.
Let's say a therapist is personally very uncomfortable with silence and sadness. A client draws something somber, quiet, and dark, and then sits with it in silence.
Okay.
The therapist, feeling their own anxiety rise, might rush in to fix it, suggesting the client add a bright yellow sun or talk about the positive aspects of the image.
Wow. They are essentially hijacking the client's process because they can't handle the discomfort.
Exactly. They shut down the client's emotional exploration to soothe their own anxiety. The guide notes that practitioners often struggle with rescue impulses or an over-identification with the imagery.
So how do they fix that?
This is the mechanism behind why supervision is mandatory in a credible training program.
Oh, that makes sense.
A practitioner needs a confidential, structured space with a senior clinician to examine their own reactions to trauma-related material, their internal biases about what constitutes good art, and the power dynamics at play.
It's like therapy for the therapist's therapy.
Pretty much. Supervision is especially critical when the therapist is facing uncertainty about boundaries or working with complex trauma.
Okay, so assuming our practitioner has mastered these foundations, they understand the psychological frameworks, they know why a huge canvas of wet paint might trigger a panic attack,
Yes.
they've abandoned the red equals anger cheat sheet, and they are discussing their own rescue impulses in supervision. How do they actually structure the hour they spend with a client?
The guide contrasts two primary ways of structuring that time: directive approaches and non-directive approaches.
Okay, what's the difference?
In a directive approach, the therapist provides a defined prompt, specific materials, or a sequence of actions.
Like giving an assignment?
Exactly. For example, asking a client to create a visual timeline of your career, or construct a mask showing how you feel on the inside versus the outside.
Directives sound really useful for providing focus, especially if a client is staring at a blank page feeling totally paralyzed.
They can be.
But the text points out a surprising clinical reality here. It notes that a seemingly innocent directive like draw a safe place might be helpful for one person, but entirely confusing or deeply distressing for another.
The mechanism behind that distress is rooted in the assumption of a shared reality.
What do you mean by that?
A prompt, like draw a safe place, assumes the client has a conceptual understanding of safety.
Oh, wow.
Right. For someone with a history of complex, chronic trauma, perhaps starting in early childhood, the concept of a safe place might be completely alien.
That is heartbreaking.
Trying to draw it might trigger immense distress because they are suddenly forced to confront the reality that they have never felt safe, or because the places they were told were safe turned out to be the locations of their abuse.
Wow. So an untrained person thinks they are offering a relaxing prompt, but they are actually stepping on a landmine.
Which is why the practitioner has to assess readiness,
Yeah.
explain the clinical purpose of the directive, and crucially, preserve the client's option not to participate or to alter the prompt entirely.
So they always have an out.
Always.
On the other side of the spectrum, we have the non-directive approach. The guide says this is where the client has greater freedom to choose the material, the subject, and the process, supporting personal agency and spontaneous expression.
Yes, very open-ended.
But I have to admit, I struggle with this concept a bit. If I'm just sitting there silently while a client paints whatever they want, aren't I just a highly paid chaperone? What is the therapist actually doing in that silence?
That is a very common critique, but it misunderstands the active nature of holding space.
Okay.
Non-directive work is not unstructured practice. Even if the client is entirely leading the artistic process, the therapist is highly active internally.
What are they doing internally?
They are holding the boundaries of the time and space, ensuring physical and emotional safety, maintaining ongoing consent, and curating the therapeutic environment. Furthermore, they are engaged in intense clinical observation.
Ah, observation. The source makes a really interesting distinction here between focusing on the process versus the product.
That distinction really answers your chaperone question. The therapist is observing the process of art making.
Not just waiting for the final painting.
Exactly. They are watching the client's material selection, their pace, their rhythm. How does the client interact with the physical environment?
Okay.
What happens when their clay structure inevitably collapses because it's too top-heavy? Does the client give up, become enraged, blame the therapist, or laugh and try again?
Oh, that's brilliant.
The clinical data isn't just in the final sculpture. It's in how the client navigated the frustration of the collapse.
Other approaches might include reflection on the final product, the completed artwork, but again, the text warns that the final image should not be treated as an objective psychological report.
Never.
The person who created the work is the principal authority on its meaning.
The physical and social setting also radically changes the rules of engagement for these approaches.
Right.
The structure of a non-directive session in a private, one-on-one clinical room looks very different from a session in a community hospital or a school.
The guide specifically highlights group therapy settings as a major shift in boundaries. It notes that in a group setting, a therapist must clearly state they cannot guarantee the confidentiality of every participant.
They can establish group rules, they can ask everyone to respect confidentiality, but ethically, they cannot promise a client that another group member won't leave the room and talk about the artwork they saw.
That's a really vulnerable position for a client.
It is. The therapist has to adjust the depth of the directives and the materials provided based on that lack of guaranteed containment.
So if we are setting up all these strict boundaries, knowing exactly what materials to use, how to frame a prompt without triggering trauma, and how to hold space without just acting as a chaperone, it really begs the question, how do we actually know this is working?
The evidence base.
Right. Is there hard data backing up these creative interventions, or are practitioners just relying on good feelings?
The guide approaches the evidence base with remarkable intellectual honesty, actually. It doesn't overstate the case.
Which is refreshing.
Very. It notes that research covers a wide range of areas like trauma-related distress, depression, schizophrenia, physical rehabilitation, and chronic health conditions.
Okay, so a lot of areas.
Yes. However, it explicitly points out that the evidence base is methodologically diverse, which is a polite way of saying it is very difficult to standardize.
Right. The text mentions that studies differ wildly in participant populations, session duration, therapeutic orientation, practitioner qualifications, and the specific art materials used.
So many variables.
Because of all these variables, systematic reviews have a hard time comparing interventions apples to apples and drawing universal, sweeping conclusions.
We have to consider why standardizing evidence is so hard in a creative psychological field. You cannot run a double-blind placebo trial on painting.
Right. Here's
Yeah.
a fake painting, please don't notice.
Exactly. You cannot give a control group a fake painting exercise without them knowing they are painting.
Fair point.
Because of these limitations, the guide advocates for a framework called evidence-informed practice. This is conceptualized as a three-legged stool.
What are the legs?
It combines the best available research, the professional expertise developed through clinical education and supervision, and crucially, client knowledge and preference.
Client preference seems massive here. Like, if the latest peer-reviewed research says clay is the absolute best medium for reducing anxiety, but your specific client hates the tactile sensation of clay on their hands, the intervention is useless no matter what the data says.
Spot on. The intervention must be monitored and modified when it is unhelpful, unwanted, or outside the practitioner's competence.
You have to listen to the person in the room.
Evidence-informed practice means adapting the science to the human being in front of you.
And this demand for honesty leads to perhaps my favorite part of the entire document, the policing of public claims.
Oh, the do not say list.
Yes. The guide includes an explicit do not say list for practitioners. I'm going to read some of these because they highlight exactly what the internet gets wrong about this field.
Just do.
Practitioners are told they must avoid statements like, this drawing reveals your diagnosis. This color always represents a particular emotion. Art therapy cures trauma. Art making replaces psychiatric care. And this incredibly heavy one image proves abuse, psychosis, or suicidality.
The harm caused by these claims cannot be overstated.
It's wild that people actually make these claims.
They do, constantly. They reduce a complex human being and a nuanced therapeutic process into a cheap parlor trick.
Right.
Treating a single piece of artwork as a standalone diagnostic instrument without clinical context is professionally reckless. Stating that art therapy cures trauma is a guaranteed treatment claim, which is unethical in almost every governed mental health discipline.
You just can't guarantee a cure.
You can state that it supports trauma recovery, but guaranteeing a cure is deceptive marketing.
The guide also emphasizes that public educational material, like a blog post or a social media reel, needs to remain accurate and proportionate. It includes a necessary disclaimer.
Which is?
Reading a blog, taking an online certification course, or attending a webinar does not create a counseling or therapeutic relationship.
That boundary protects both the public and the practitioner.
Yeah.
The strict policing of these claims and the insistence on evidence-informed practice naturally leads us into the unique and often unexpected ethical minefields that are entirely specific to this work.
Let's get into the ethics.
When you introduce a physical object, the artwork itself, into the therapy space, you multiply the ethical complexities exponentially compared to standard talk therapy.
Let's unpack those complexities, starting with informed consent. In standard therapy, you sign a consent form regarding confidentiality and billing.
Pretty standard intake stuff.
But the source clarifies that when art is involved, informed consent is an ongoing process, not a one-time signature at intake.
Because the art exists outside the session.
Right. A client agreeing to participate in art therapy does not mean they automatically agree to have their art photographed, published in a journal, exhibited in a hospital hallway, or used in the therapist training seminars.
Exactly. Consent has to explicitly cover the right to decline an activity, the potential for emotional discomfort during the creative process, how the physical artwork will be stored, and who can access it.
The storage and privacy aspect is wild to think about. When I talk in therapy, my words disappear into the air. But if I paint something, it is a tangible record.
It is medical documentation, essentially.
The guide points out that artwork can contain highly sensitive identifying information, even if the client's name is removed from the back of the canvas.
The clinical privacy laws that govern session transcripts apply equally to visual records. The text lists potential identifiers hidden in artwork.
Like what?
Faces of family members, specific neighborhood locations, religious imagery, specific life events, and even just the client's handwriting incorporated into the piece.
Oh, wow. Yeah, handwriting's a big one.
Keeping a physical or digital record of an artwork requires clear policies on secure physical storage, encrypted digital security for photographs, safe transportation, and secure disposal of the art when the retention period ends.
So no casual Instagram photos.
Absolutely not. Written permission for the client to make the art in session does not imply permission for the therapist to snap a quick photo on their iPhone and put it on their professional Instagram page to market their practice.
That brings up a fascinating point about how we interpret the content of the art itself, especially regarding cultural responsiveness.
This is a huge area of ethical risk.
The guide firmly states that art is not a universal symbolic language.
This goes back to the danger of universal interpretation we discussed earlier, but on a macro level.
Like interpreting for a whole culture.
The guide explicitly challenges practitioners to examine Western-centric psychological models. Depictions of death, family structures, relationship to nature, or even specific colors carry vastly different meanings across different global communities.
The text says culturally responsive practitioners should ask rather than assume. They need to consider caste, class, religion, race, gender, and disability.
They have to respect sacred and community art traditions.
You can't just take a sacred symbol or a traditional pattern from a culture you don't belong to and use it as a casual drawing prompt for a client, assuming it just means spirituality.
That level of care is paramount, and it extends directly into trauma-informed safeguards.
How so?
Creative work bypasses the rational brain. It can activate somatic memories, physical sensations, or deep emotional distress in highly unpredictable ways.
Right.
A general certification in art therapy does not independently qualify a practitioner to undertake specialized trauma treatment. They need clear session boundaries, advanced emotional containment skills, and established referral pathways.
Okay, let's apply this to a high-stakes scenario. Let's say our listener is that HR manager we keep mentioning.
The one in the windowless conference room.
Exactly. They are running a corporate wellness painting session. An employee who has been visibly stressed paints a highly concerning image, something that implies imminent harm to themselves or someone else.
Okay, a crisis moment.
Doesn't the facilitator or therapist have to act on that drawing immediately?
The guide provides a very specific crisis disclaimer for this exact scenario. A concerning image is not a definitive disclosure, and it is certainly not a medical diagnosis.
Okay.
However, it is a reason for careful professional inquiry.
So you don't look at a dark, violent drawing and immediately call an ambulance or building security based purely on the paint on the canvas.
Correct. The art might open the door to a conversation about risk, but the art itself is not the diagnostic tool that triggers the emergency response.
It's the conversation.
The clinical assessment is you ask the client about the drawing, you use standard verbal risk assessment protocols. If that inquiry reveals acute psychological distress, imminent risk of self-harm, suspected abuse, or medical instability, that requires prompt intervention from licensed clinical professionals or emergency services.
So the art is a signal, not a siren.
Art activities are not emergency interventions, and relying on them as such is dangerous.
That distinction is critical for anyone trying to implement these practices. With all these ethical risks, potential for harm, and complexities around cultural interpretation, how does a prospective learner or an employer looking to hire someone actually spot a legitimate training program versus a scam?
It is tough out there.
If I'm looking online right now, how do I know it's real?
That is the practical reality of a largely unregulated digital landscape. The quality of programs varies wildly. The guide provides a robust due diligence checklist for spotting credible providers and identifying the fakes.
Let's run through the green flags and red flags.
Okay.
A massive green flag the guide mentions is that a credible provider must publish the full curriculum before enrollment.
No secrets.
Right. You should be able to see the module titles, the specific learning outcomes, the assessment methods, and the credential verification procedures before you ever input your credit card information.
Transparency is a baseline requirement. Another critical area is examining faculty competence.
Okay, what are we looking for there?
The guide emphasizes that personal experience with art is not enough to teach this material. Faculty need demonstrated research literacy, advanced clinical expertise, and real-world experience with the client populations addressed by the program.
We talked about assessment gating earlier, and the guide brings it up again here. A brief, open-book, multiple-choice quiz might test whether you memorize the definition, but it cannot demonstrate advanced relational competence or ethical judgment in a crisis.
It's just too superficial. Building on that, the red flags are usually centered around overpromising and underassessing.
What are the biggest red flags?
The guide lists several warning signs. Providers concealing the curriculum until payment is made, programs promising legal authority to practice everywhere, globally.
Oh yeah, that's a big one.
Awarding certification based purely on a written quiz without practical assessment, teaching that universal image interpretation is real, and making guaranteed treatment claims like, become a certified trauma healer in 30 days.
It's always 30 days, isn't it?
Always. If a program promises you will be a licensed art therapist worldwide with minimal effort, it is fraudulent.
So if someone goes through a legitimate, assessment-gated, highly rigorous program, how do they actually use this certification in the real world? The guide breaks down how different disciplines apply these skills.
It creates a clear boundary between clinical and non-clinical applications.
Okay.
Qualified mental health professionals, people who are already licensed psychologists, social workers, or psychotherapists, use this certification to extend their existing therapeutic repertoire.
So they add it to their tool belt.
They learn to use visual methods more purposefully, improve their visual consent procedures, and use metaphor more effectively in session. But they are still working strictly within the legal scope of their original statutory qualification.
And for the practitioners in adjacent disciplines like occupational therapists, special education teachers, or our HR professional, they might use the training to facilitate creative well-being activities or support fine motor skill development.
Yes.
But they absolutely cannot call those activities psychotherapy.
The guide is uncompromising on that point. In organizational settings, facilitators have to clarify to participants if the activity is voluntary, who will see the artwork, and what the protocol is if someone becomes emotionally distressed during the exercise.
You can't just spring it on people.
You cannot run a mandatory corporate team-building drawing exercise and present it as confidential psychotherapy. It's about truth in advertising, maintaining professional integrity, and ultimately protecting the public.
But professional certification demonstrates the completion of rigorous training and assessment. It does not replace statutory licensure or grant you a title you haven't legally earned.
It is for professional upskilling, allowing you to use creative tools safely and effectively within the boundaries of the job you already have.
So as we wrap up this massive deep dive into Pragya Alexander's guide, the overarching takeaway is abundantly clear. Art therapy is an incredibly powerful mechanism for healing, but it demands profound professional responsibility.
Absolutely.
The physical materials are not neutral, the interpretations of the art are never universal, and the ethical boundaries from storage to crisis response must be rock solid.
It is a profoundly complex and beautiful field when it is practiced correctly. And as we consider everything we've unpacked today, I want to leave you with a final thought that builds on the text points regarding artwork ownership, privacy, and the evolving nature of meaning.
Oh, intrigue.
We talked about how the physical art is stored and protected. Imagine a piece of artwork created by a client in a deeply emotional session. It is safely stored away by the therapist, locked in a secure filing cabinet, perfectly preserved in the exact state it was created.
Right.
But outside that cabinet, the client continues to live. They continue to heal, they gain new perspectives, and they change. Years later, their memory and interpretation of that specific artwork might completely shift.
Wow, yeah. The physical drawing in the cabinet hasn't changed a single pencil stroke, but the client's relationship to what it represents has fundamentally altered. This raises a philosophical but highly clinical question.
What's the question?
Where does the truth of that therapeutic moment actually live? Is it locked away in the preserved physical product? Or does it exist entirely in the client's endlessly evolving internal process? It is something for you to mull over.
Process over product. Always. That's a brilliant note to end on. If you want to get yourself certified, log on to therapycouncil.org. We have a range of certification to offer, and for more such deep dives, click the subscribe button and hit the bell icon.